in the groups.
Good afternoon, delegates and all the participants. Today we are back with our series, The Icons in Conversation with Dr. Ritu. And this is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar. And today's topic is non-invasive prenatal testing. So before starting the session, let me introduce Dr. Ritu ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is infertility specialist. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am.
Thank you, Sahiti. Please stop sharing the screen. So knowledge is confidence. Knowledge always increases by sharing. With this motto, I started this series at the time of the lockdown. So every time, every week, I'm inviting one of the stalwarts from the field, and they're going to discuss some of the very important topics. The topics are from basics to advanced because this program has been attended by not only from the stalwarts but also from the PG students and all across the geography. I'm really thankful to Shield Pharma for providing the constantly the platform from last 3 years. And warm welcome to all dear delegates who have joined all across the geography. Friends, today the topic is very important, the non-invasive prenatal testing. We all know these days, a lot of the patients, of course, we are doing the Down syndrome testing, we are doing the anti-scan, we are doing the double marker, we are doing the quadruple marker. But when to proceed for the NIPT, what are the pros and cons to discuss for this? We are having a one stalwart with us, Dr. Manjeet Mehta, madam. Madam, warm welcome to you. Madam has taken out her precious time in spite of her very busy schedule. I am really thankful to madam that madam is these days she is doing the lot of CMEs for SPAT, and every day she is going here and there. In spite of that, once I requested madam, she has accepted the invitation. So warm welcome to you, madam. Sahiti, please introduce the madam.
It's my privilege to introduce Dr. Manjeet Mehta, ma'am. Ma'am has been the medical geneticist with over 30 years of outstanding work done in human reproductive genetics. Ma'am has so many certifications and international trainings. Some of them are Certified Associate Genetic Counselor by Board of Genetic Counseling India, Certified Clinical Laboratory Geneticist, European Society for Medical Oncology, Associate Member of Canadian College of Medical Geneticists, Technical Assessor at NABL for Genetics and Molecular Biology, Certified Inspector for College of American Pathologists. Ma'am has received numerous awards, including Award of Excellence for Contribution to Genetics in India, Worldwide Achievers Healthcare Excellence Award for Research in Cancer Diagnosis, Women's Achiever Award and Certificate of Excellence by IIFS, Champions of ISAR Award, and ma'am has 35 publications to her credit and 12 book chapters and 230 national and 18 international presentations and 28 research projects. So I welcome you, ma'am.
Warm welcome, Manjeet madam, and madam is currently in the post of the secretary for the National SPADA. Warm welcome to you, ma'am. Ma'am, now all the dais is yours. Post your lecture. Whatever the questions we will receive, we will take that. Ma'am, before you start, we can welcome our delegates who have joined across the geography. Dr. Samuel, we can see here, Dr. Samuel has joined all the way from Nigeria. Warm welcome, Dr. Samuel. Geeta Khanna madam has joined from Lucknow. And so many other friends have also joined. Yeah, hi, Dr. Samuel. How are you?
Good morning, ma'am. Namaste. Namaste.
Namaste. Namaste. So nice of you. You always try to join. Yes, over
Thank
to you,
you,
madam.
Thank you very much, Dr. Ritu. This is some really amazing work that you are doing in, sharing all this knowledge through your connects with everybody through this platform. So I will get started with my talk right away. I'm going to talk today on non-invasive prenatal testing. Of course, this has been around for quite a while now, and just trying to clear off the basics. There would have been some queries now that people have started using this technology, and then the indications and the advantages of it. So, non-invasive prenatal testing is, I'll be covering in this background of NIPT, the utility in clinical practice, and then in the general populations, there have been queries in twins and for microdeletions, and whatever the best practices are. So what is NIPT or even NIPS? Why it is called NIPS is because it is a screening method. It is not a confirmatory or a diagnostic test. It is a testing of cell-free DNA from maternal blood during pregnancy to rule out the common trisomies 13, 18, 21 and abnormalities of the sex chromosomes X and Y. So we can pick up with this triploides, we can pick up microdeletion syndromes, some rare autosomal trisomies will also be picked up with this, and then some other conditions. Because it is just the maternal blood, it is absolutely safe and also, as we say, non-invasive. The first question that arises is why screening is important for chromosomal abnormalities. Every woman has a desire to have a normal baby and to have a spontaneous conception. We are generally seeing an increase in the number of women giving birth later in their life because of the job, because of other responsibilities. People are pushing their conception to, when they are even in their 30s very frequently. These abnormalities are relatively quite common. If you see the combined risk of all of them, it is quite high. We also need to consider they all have a considerable financial, social, and economical cost. And we would like to prepare the lady for a birth of for an abnormal infant. It becomes very painful and expensive also. And this has been recommended by all professional societies. If you see the incidence of these abnormalities in India, you can see that every year there are more than 7 lakh abnormal children being born with either some kind of a congenital malformation, chromosomal disease, Down syndrome, which is a very common cause of mental retardation, and also trisomy 13. Now, if you see the conventional ways of screening pregnant ladies, age itself is a high risk. So somebody who falls in the higher age group, by themselves, they are in a high risk range. We have been having since several decades the triple marker, the quad marker, both of which are biochemical markers. And then we have a combined screen. And then the latest and the most sensitive is the cell-free fetal DNA, that is the NIPT testing. Now, screening for all is something which is our aim, our goal. We hope to reach that place sometime. The reason for this is we are able to pick up and separate the low risk from the high risk people. And once we know that these people are in the low risk category, we have the regular surveillance which needs to be done for them. And high risk people need to go in for a confirmatory diagnostic test. It confirms whether the disease is present or absent. And then it is best applied to a group of high risk populations. Why? Because it's an invasive test. It carries with it the risk of procedure, and it is not to be done on everybody. So in the screening test, what we have had historically, the maternal biochemistry, dual, quad, triple, USG markers, and the diagnostic or the invasive or the confirmatory tests include chorionic villus sampling and amniocentesis. And now to add to that, we have this NIPT, which comes in the category of screening test. It is extremely high sensitivity. Having said that, it is a screening test and not a diagnostic test. So what is the principle of this non-invasive prenatal testing? this cell-free fetal DNA, it most probably arises from the placenta, and it is circulating in the maternal circulation. So the maternal blood contains both fetal as well as maternal DNA, and around 2 to 20% of the total cell-free DNA is fetal in origin. This, anytime after 7 weeks of gestation, the percentage is increasing. The number of these cells in the maternal circulation is increasing. And then after delivery, of course, it just clears from the system. So this was first discovered in 1997 by Dennis Lowe. And then in the mother's blood, he saw the DNA of both mother and fetus. And as I said, this clears rapidly from the maternal circulation after the baby is delivered. So the way we separate it is the sample that is taken, the DNA is extracted. We get the maternal DNA as well as the fetal cell-free DNA, and these are sequenced. So the beautiful technology that we have, next generation sequencing, it's called a massively parallel sequencing. And both the sequences are available for us. And then we align it, and then we are counting it. We check the fetal fraction, and therefore we label the baby as either no aneuploidy or a high risk for aneuploidy. So this is the way, if you see the threshold that is there, anything that's below the threshold, if the pink bar and the blue bar, so they are normal for chromosome 13 and 18. Whereas this green bar, when you see, it is going above this level. So that is a fetus with a possible trisomy 21. So coming to the indications for NIPT, advanced maternal age, as I said, by itself is an indication. I mean, along with a normal ultrasound. A high risk for aneuploidy on a combined screening, if you're doing a dual quad and an NT scan, if it's coming high risk in that, with a normal ultrasound, this is a candidate for NIPT. Even an intermediate risk on dual quad with a normal ultrasound, and a history of previous downs or a parental balance translocation. Now, if you notice in this, all these indications insist on a normal ultrasound. Because if you find any abnormality in the ultrasound, which could indicate some congenital abnormality in the fetus, there is no point going in for a screening test. Then it's better to go in for an invasive confirmatory diagnostic test. So when not to do NIPT, if you see any abnormal USD findings, it's better to go directly for a confirmatory invasive diagnostic test. Around anytime after 10, 11 weeks, so, because they start circulating by 9 weeks, so below 12 weeks. Above 17 weeks, why it's contraindicated is because it's being a screening test. If you need to go in for a confirmatory test, you do an amniocentesis, you send the sample to the lab for testing. By the time the test results are out, we are racing against time here. So you need to understand that if you need to take a decision based on these test results, you have to be within the period that is an NTP is permitted. Previous failed NIPT, vanishing twin, or triplets which have been reduced to twins. So NIPT can be performed after 9, 10, 11 weeks approximately. We do it after a 12-week ultrasound, and again before 17 weeks, as I have just explained. So if it is a low risk, you continue with the regular surveillance. If it is a high risk, it's better to go in for an amniocentesis and get a diagnostic confirmation for that. The major advantages of NIPT, it has a high detection rate as compared to other screening methods. As you had seen in the previous slides, the other screening methods have a detection rate of anywhere between 70 to 75%. And NIPT goes to 95 and even 99%. This has a lower false positive rate compared to other screening methods. and a high negative predictive value. So therefore, it avoids unnecessarily invasive procedures in precious pregnancies. And then because it is a very high sensitivity, it helps in reduction of the number of invasive procedures that are to be carried out. So now I'll explain this point of what I just said about the whether it is a true positive or a false positive. So the positive predictive rate, the higher it is, So consider we have got 100 ladies who are, high risk for a trisomy 21. Now, if this high risk figure has come from a first trimester screen and we go to an invasive procedure, out of the 100, only 3 will be true positive, whereas 97 of them will be false positive. On the other hand, if we get a positive, like high risk as per NIPT testing, and then we go in for a diagnostic invasive procedure, so 91 of 100 will be a true positive, and only 9 of them will be a false positive. So then, this leads to lesser anxiety for the patients, lesser invasive procedures that need to be done. So that is the reason why this is an excellent, technology, and there is no stopping offering it to all the pregnant ladies who are concerned about having a normal baby. You must have read this and several other reports, baby gets Down syndrome, patients allege negligence on part of the doctor. So today the people are really aware, they are educated, they are looking up on Google, they are reading and they are understanding. And if they deliver an abnormal child, be it Down syndrome or be it any congenital abnormality, and they know that these can be picked up prenatally, these can be suspected prenatally, these can be tested for before the baby is born, then they expect that treatment to be given to them. If you feel your patients will not agree, what you could do is to inform them that these are the chances, this is a prevalence, this is the incidence of this condition, these are the tests that are available, this is the cost of the test, this is the sensitivity of the test. If they don't want to go ahead with it, it's perfectly all right. You just take it's called a negative consent. You just take the signature that they have been informed of these risks and they do not want to proceed with the testing. I mean, there could be people who are high risk due to certain other factors and they do not want to do the test. So it's always better to inform them of the available options. And then, of course, the decision is theirs. We cannot force them into doing anything, but we have to keep ourselves legally safe. So, coming to micro deletions, there are a few micro deletions which are quite common, and you see high incidence of them at birth. These micro deletion means a part of a chromosome is missing, as against the trisomy syndromes wherein the entire chromosome is in 3 copies instead of 2. In a microdeletion syndrome, there is a small segment of the chromosome which is missing, but which gives rise to a whole lot of clinical phenotypes. So it's better to test these also at a prenatal stage. Microdeletion testing can be done through a non-invasive sample, and these are the common microdeletions which are offered by many laboratories through an NIPT sample. So a screening test and confirmation test is still essential, even in microdeletions. And many times you will pick up some structural abnormality. You will see something on the sonography, and it's useful when patients want to avoid invasive testing. It gives them a good screening with a very high sensitivity. All international OBGY societies have strongly recommended the use of prenatal screening for every pregnancy. Now, how far you want to go? whether it's just sonography, whether it's just the biochemical markers, whether you want to add on NIPT, you have to take a call, seeing the patient history, seeing the clinical indications. But every international body has issued a statement, emphasizing the importance of prenatal testing just to avoid the birth of an abnormal baby. So the risk stratification for aneuploidies, if you see it, if it is on a combined first trimester screen, if it is a high risk, go directly for a CDS. If you've caught it in the first trimester, or else if it's already 15 plus weeks, you can do an amniotic tooth. But if it is a high risk, just go in for an invasive procedure. If it is a low risk, continue with the routine care like we would do. But if it falls in the intermediate risk group, then you need to check the ultrasound markers. Are they normal or are they abnormal? Accordingly, if it is normal, you could go ahead with an NIPT, which is a very high sensitivity screening method. If as it is you're seeing some abnormalities on the ultrasound, you could directly do an invasive testing to get it confirmed that if it is something genetic or if it is something just structurally, just one defect. And NIPT, again, if it is a low risk, you continue with the routine care. If it is a high risk, that will mandate an invasive screening. But then by doing NIPT, we are eliminating the need for many additional invasive testing. Again, in low risk also, you keep in mind that if it is age high, the age is high, if it is an IVF pregnancy, previous trisomy 21, so they become again high risk because of this, although their biochemical screening is a low risk. So very important to give a pre-test counseling, take an informed consent. We need to explain to them what we can pick up by the test and what we cannot pick up. What are the abnormalities that will be ruled out by this testing? How safe the procedure is. If it is a high risk, they will definitely have to go in for a diagnostic testing. And if they're not going to go in for a diagnostic testing, then why are they doing an NIPT in the first place itself? We need to explain to them to be able to be sure that the baby is going to be normal. This is the steps and these are the processes. We need to explain the difference between screening and diagnosis. There are very few screen positive or high risk which are actually normal when an amniocentesis is done. So all that needs to be explained to them. Also, it is important, and nothing can replace NT scan and ultrasound scan. And even if it is a low risk NIPT, the regular USG scans need to be done, at regular intervals. Once the test results are also ready, another round of counseling and explaining to them that it is a screening test. It's not a diagnostic test. This does not rule out single gene disorders. It's very important. The pre-test and the post-test counseling really need to be done very well. So just to sum it up, non-invasive prenatal testing stands for the three common aneuploidies: Down syndrome, Edwards syndrome, Patau syndrome. Sensitivity is greater than 99%. Anytime after 10 weeks, this test can be done. And it is a maternal blood test which detects the pre-fetal DNA in the maternal blood. It should be offered to people with an advanced age, abnormal blood markers, having a normal USG. Do not offer it if the USG is abnormal. Is it a diagnostic test? Can we terminate if NIPT is high risk for trisomy 21? No. It is a screening test and it needs to be backed up with another diagnostic test. So thank you very much. Just try to give a brief overall of this technology. and its applications and limitations. I am open to questions if anybody would like to.
Thank you, madam, for such a wonderful presentation. You tried to cover all the points. Really a very enlightening lecture. Thank you. Thank you so much, madam. It's a good to see Dr. Sanjay Jadhav has also joined. Yeah, hi. Mona, I think, has left. Friends, if there are any questions, we can take that questions now. Let me check here.
So I would also like to mention over here there are different laboratories offering different technologies. Some of them do all the aneuploidies, like of all the chromosomes. Some of them do 9 microdeletions. And as science is advancing, as technology is advancing, we are gaining more and more information on this. Recently, we have started NIPT for single gene disorders. We are trying to be able to pick them up, on a non-invasive test, or rather than going in directly for a diagnostic test. So something like a beta thalassemia, if there is a family history or they belong to a particular ethnic group, if we can get it from a non-invasive test, there'll be nothing like that. So uh, these are the advances, that is happening, and we are trying to do the whole exome soon. I think that day will be here very soon.
Thank you. Thank you, madam. Madam, there is one question from Dr. Sanjay Jadhav, sir. Sir is writing, just a second. I think it's in the chat box. Yeah. What is the sensitivity for other aneuploidies?
So sensitivity for all the aneuploidies is 99, greater than 99%. It's only the sex chromosomes where the sensitivity is approximately 94 to 95%. So these are the sex chromosome aneuploidies that you get it while doing an NIPS, they are not so reliable as of now. And other aneuploidies, besides these three common trisomies, most of them are not even compatible with extrauterine life. So honestly, you don't need to be too worried about it, because I mean, nature has a beautiful way of expelling fetuses which are grossly abnormal, So this mostly will end up with a first trimester missed abortion or a second trimester fetal device, because none of the other abnormal trisomies, aneuploidies, are compatible with extrauterine life. Having said that, the sensitivity, to answer your question, is the same for all the autosomes. For sex chromosomes, it's slightly less.
Thank you. Thank you, madam. I think we haven't received today any questions. Madam has explained all the things very nicely. Let me check in the YouTube. Just a second. No, till now there are no questions. Only we are getting the appreciations. Very nice presentation. So thank you once again, madam, for taking out your time for this webinar. Thank you so much. So
Thank
as
you for
there are
having me over.
friends, as there are no more questions, and I know this is the open. Madam, you receive one more compliment from Dr. Sanjay Jadhav, the wonderful presentation. I must say, madam's always slides are very crisp. I attended one more talk of the madam on last Sunday only when madam was here in Pune. A very crisp presentation, to the point, nothing extra. What the things is required, that only she has covered. Um, Okay, one request has come, madam. Can we have one session on different genetic tests?
Of course. Yeah, we'd love to have
So,
it. And actually, that is a need of the hour. And I'll tell you the reason for this, no? Because genetics is advancing so much, so much. And there are so many new technologies. And previously, we had so-called laboratories run by geneticists. Today, we've got companies because they get the equipment and they're adding and adding newer panels, newer profiles. So if you have a case in your hand, you need to understand exactly what will be the best technology that needs to be applied to them. And I have had people coming and they've gone and spent so much and they've done very elaborate reports, but none of them are appropriate. none of them actually pinpoint the cause which is clinically suspected. So if you have a clinical suspicion, you want a confirmation, you need to do the right test, to be able to diagnose it. We can have that sometime.
Thank you, madam. One more comment from Jadhav sir only. Like NGS, whole exon sequencing, etc. Yes, madam. I will take time from madam. So whenever madam give me the time, I will plan for the another session with the madam. Dr. Neerja has given the comment, very crisp and informative session. So thank you for joining, everyone. Acha, okay, I will do that. I will do that, Sanjay Jadhav sir. Sanjay Jadhav sir is telling me. So, madam, I will request to give me the time for some another session. So,
We'll do
I
it.
will take your time, then accordingly we can plan for that. So, I think if there are no more questions, we can wind up for today. Yeah, we can wind up for today. So thank you all, dear friends. And once again, thank you, Manjeet madam, for joining. Thank you, Shield Pharma. A big thanks to my dear Sahiti for always being me with here. Sahiti, can we give a token of appreciation to Manjeet madam? Can you please share the certificate?
Yes, ma'am.
उनको लो. Madam, this is a small token of appreciation.
Oh,
The
nice.
icons and conversation with Dr. Ritu, certificate of appreciation to Dr. Manjeet Mehta, madam, for contributing as a distinguished speaker on 28th March 2024. Thank you, ma'am. Thank you so much.
Thank you, everybody.
Thank you. So, friends, with this, we are winding off for today. Bye-bye. We'll meet you next week.